Hello, hey, how are you? Hey guys, I just wanted to do a quick review on pediatric emergencies. Now, this was again a 4-hour lecture, 4 hours, and I'm just going to pick the top 10 slides. I'm going to pick 10 slides to go over in order to prep you for the final in pediatrics or your pediatric exam. So again, just top 10. Okay, so respiratory distress in pediatrics. So big thing to remember here in this one is that cardiopulmonary arrest begins with respiratory distress first. So most of the time, pediatric patients have respiratory distress. They can compensate. They have very strong compensatory mechanisms. So they compensate, and then they have arrest. And the cardiopulmonary arrest originates from the pulmonary distress. So the heart doesn't get, because of hypoxia, the heart doesn't get enough oxygen, and the heart will start to fail by having some bradycardia, some real slow heart rates, and then cardiac arrest. But the origins are generally from hypoxia, from respiratory distress. Here's our pediatric assessment triangle. So this is otherwise known as an across the room assessment. So most of this we should be able to do hands-free. We should be able to look across the room without touching the pediatric patient and get an idea of how our child is doing. So there's 3 sides to the triangle. The first side we can look at is appearance. So we should see an infant in a position of flexion, hands and knees flexed. Older than an infant, they should be alert, looking around, following and tracking their parents. They should be apprehensive of strangers. That should all be a normal appearance for pediatric patients. When we see pediatric patients that are lethargic, or they're not alert, or their limbs are flaccid, that is a very bad sign that our appearance triangle is abnormal. Work of breathing, this is when we're going to look at our retractions, grunting, flaring. This is our work of breathing in the pediatric patient. Do we hear any audible airway sounds? Like, do we hear snoring? Do we hear stridor? Do we hear audible wheezing? And circulation to the skin, we're going to look at our color, our temperature, and then a very good indicator of pediatric distal circulation is capillary refill. Okay, so when we're looking at our work of breathing, these are the things we're going to look at. Altered mental status, this would really be a late sign, and it would be when we see patients who aren't getting enough oxygen to their brain, and they would have an altered mental status. So that is not, it's a very ominous sign. Flared nostrils in infants and children, they don't have as much developed cartilage. So when they inhale, when they're really having increased work of breathing and trying to pull air in, sometimes their nostrils will flare. It's a sign of work of breathing. Bluish, pale or bluish lips or mouth, or circummoral cyanosis, another term for that. That's a sign of hypoxia. Stridor or grunting. Grunting is a sign of respiratory distress, and it's commonly associated with pneumonia in children. Stridor is our upper airway obstruction, like this could be croup or aspiration. We're going to look at our retractions next. We're going to look at suprasternal right here where my cursor is, so just above the sternum, supraclavicular above the clavicles, intercostal in the middle of the ribs. We can have subxiphoid or substernal underneath the sternum. Those are all retractions and increased work of breathing. We could have tachypnea or breathing rate greater than 60. Wheezing, work of breathing, struggling to breathe, decreased muscle tone, poor perfusion, this is from hypoxia, and use of abdominal muscles. Now, in infants, abdominal muscle use, belly breathing is normal, where you see the belly rising and falling with inspiration and exhalation, it can be normal, but when they're really having like a paradoxical breathing or a seesaw respiratory pattern, that is a sign of respiratory distress or increased work of breathing. Okay, so a couple things to think about in pediatrics, oropharyngeal airway. We measure this, the corner of the mouth to the angle of the jaw, and we insert it with the tongue depressor, as you can see in this picture. It's guided along with the tongue depressor so we don't do any damage to the soft palate at the roof of the mouth. And then remember, babies have a large occiput, which puts them in a position of flexion. This baby really isn't in neutral alignment, and we would never want to immobilize like this. Remember, infants have C-shaped rings instead of O's in their trachea. They have a C. So when there's a deep flexion or extension, if they're not in neutral alignment, it can just flatten out because it's only in a C shape. So we want to they have this large occiput back here, which pushes their head down into flexion. So we need to put padding under the torso or the scapula to put them in neutral alignment, especially before we're going to immobilize or if they're in any distress before positive pressure ventilation. We really need to make sure our babies are in neutral alignment. Dehydration. Okay, so here's some specific signs of dehydration in infants. So sunken fontanelle. So the fontanelle should be flat. If it's bulging, it could be a sign of increased intracranial pressure from a head injury or meningitis. But a sunken fontanelle in infants could be a sign of dehydration. When the eyes are sunken, when they're crying and there's no tears, they may be very thirsty. And then they don't have as much urine output. So we ask about diapers when we're collecting our history from parents. So vital signs, we could see rapid breathing from dehydration, increased heart rate as a compensatory mechanism for the hypovolemia. Restlessness and irritability is an early sign. Lethargy and weakness is a late sign. And really, decompensated shock is an altered LOC. And then poor skin turgor. So these are signs of dehydration that we look for specifically in infants. Mucous membranes, their mouth should be moist. If it's dry, it's a sign of dehydration. And then again, remember, capillary refill is a reliable indicator of distal circulation. Okay, a few respiratory diseases here to talk about. Croup, this is an upper airway obstruction. The virus causes a narrowing of the upper airway. It can cause a barky cough like a seal. It's mostly at night. It's worse at night. A steamy shower room helps, like if the shower gets really hot and steamy in the bathroom. That can help. Also, bringing them from inside to outside can make a difference in their breathing. And the treatment is really assessing and recognizing oxygen in transport. Epiglottitis, this is the tripod position. Drooling, these patients are really, really sick. We're going to give some blow-by O2 in transport. We're never going to try to make them cry. We're going to try to be as hands-off as possible. And the blow-by O2 just to give them some oxygen, but identify this and quickly transport. Asthma, this could be bronchoconstriction from allergens in the environment. You may hear an audible wheeze. There's a treatment could be beta-2 agonist if it's prescribed. And bronchiolitis, this is infection and lower airway obstruction. It can lead to pneumonia. It causes an increased work of breathing in infants and babies. It causes them to not be able to drink their bottles. They can sometimes get dehydrated. They can have symptoms of dehydration and respiratory distress. Pediatric emergencies to talk about meningitis. So meningitis, nuchal rigidity, that's a stiff neck, fever, seizures, irritability because they have a really bad headache, they just can't tell you, and the purplish rash. And we want to make sure we have good PPE with the HEPA mask on this one. Febrile seizures, so this could be if the temperature goes up too high, too fast. We really just want to protect from injury, and you should only have one seizure per illness for a febrile seizure. We just want to remove their clothing and transport. And status epilepticus, remember if there's two seizures that there isn't a period of being lucid in the middle, or it's longer than 15-20 minutes, it's status epilepticus. Remember abuse if there's bruises in various stages of healing, pattern bruises, scalding injuries with sparing like the glove or the donut burn we talked about in class, or when the history doesn't fit the injury. And for ingestions, we never want to force any charcoal. Charcoal doesn't bind to strong acids, alkalis, alcohol, heavy metals. So we always want to call poison control. We could try to put the charcoal in like a sippy cup and try to get them to take it if they are completely awake and alert. Then, but we always want to call poison control. Just a couple reminders for CPR in pediatrics. The depth of compression is the same for an adult, 5 centimeters for a child, 5 centimeters for an adult, 4 centimeters for an infant, and for both of those, it could also be 1/3 of the chest. Positive pressure ventilations, we want to make sure the airway is in neutral alignment. Again, we may need to put padding underneath the scapula or the torso. And strong compensatory mechanisms for shock. So early, you can see delayed capillary refill, tachycardia, cool, pale skin. When we have hypovolemia or shock, we're going to shunt all of our blood to vital organs. Non-vitals aren't going to get much. And late sign of shock is when the brain isn't getting enough oxygen, so altered LOC. And remember, in pediatrics, the blood pressure is really not the best indicator. It's difficult to get. Every time they flex their muscle and cry and fight you, the needle moves around. So it's not our best indicator of shock. We're really going to look for an altered LOC. A couple things about trauma. We want to make sure you immobilize them again in neutral alignment. You may need to pad the torso or the scapula. We never want to restrict the diaphragm. It's the major muscle of breathing. That's why we crisscross our straps when we're doing immobilization. Remember, the ribs are very compliant, so suspect underlying damage without fracture. So pulmonary contusion or myocardial contusion, even if the ribs are all intact. And lung sounds can be easily transmitted from the thin chest wall. Okay, so that's all I have for pediatric emergencies. I hope this is helpful. I'll see you all soon.